Our next speaker is Professor Rajiv Khanna from QIMR, Berghofer Medical Research Institute, Australia. Professor Khanna has been awarded Order of Australia in 2017 and has been elected as a Fellow of Australian Academy of Health and Medical Sciences. Topic of Professor Khanna's talk is combining immunodiagnostics and immunotherapy for clinical management of infectious complications in transplant patients. Over to you, Professor Khanna.
Good morning, everybody. Today I'm going to speak on the topic how we can combine immunodiagnostic and immunotherapy for clinical management of infectious complications in transplant patients. Here are my disclosures. In particular, I want to highlight our links with Atara Biotherapeutics. This company we have been working with for almost now 4 to 5 years on development of the T-cell therapies for CMV and EBV. Infectious complications remain a significant challenge, and there are 3 different stages when these infections cause significant morbidity and mortality in transplant patients. In early phase, we often see bacterial infections. And then we see the middle period, the late period, which is going up to 6 months or beyond. You start seeing reactivation of these viral infections. These are persistent latent viral infections. Particularly, I want to highlight the infections like Cytomegalovirus, Epstein-Barr virus, or varicella-zoster virus. These viruses often arise from the recipient himself. Either these are latent infection getting reactivation, or you could get actually infection being transmitted through the transplanted organ or stem cells bringing these infections. It is very critical to identify what the source of these infections are. What are the strategies used for the treatment of these or prevention of these viral reactivations? Every clinical center seems to have a different strategy. The traditional way is to treat all patients, that is to give them antiviral prophylaxis from day 1 and continue up to 3 to 6 months, or even longer than 6 months, up to 9 months in heart and lung transplantation. There are other options available as well. For example, the Royal Brisbane Hospital in Brisbane uses a preemptive strategy. What do you mean by preemptive is that the patient is continuously monitored for any viral reactivation, particularly in this case CMV or EBV. And if there is any evidence of certain level of viral reactivation, the patient is only given treatment if there is detectable virus. The other strategy is to use a combination of both preemptive and prophylactic therapy, and whereas the patient could initially be treated using preemptive strategy or given early prophylaxis and then preemptive strategy. So you give him a set period of prophylaxis, and then using whether there is any reactivation of the virus, you give the preemptive therapy. However, the long-term use of these antiviral drugs do cause significant problems, and in particularly the drug resistance remains a significant challenge. The other problems are the toxicity and the cost of these drugs. And it's been reported in the literature that the long-term use of these virus and drugs causes late viral diseases or late viral reactivation. And approximately 20% of these patients show viral reactivation or the late viral reactivation. And the mortality and the morbidity in these patients is extremely high and could be up to 40 to 50%. There has been a number of attempts made to either predict or identify patients who are at a high risk of developing these viral reinfection. We have been interested in this area for many years and have tried to develop an immunological sort of a strategy of monitoring to monitor the infectious complication in the transplant patient. In collaboration with an Australian company, Celestis Inc., which is now owned by Qiagen, we actually have developed a simple whole blood test, which is now marketed in Europe and in Australia and also in US. It is referred to as QuantiFERON-CMV. This QuantiFERON-CMV kit includes 3 tubes. One tube is nil, that is, it's got anything, and the other tube has second tube has the CMV peptides, and third tube has mitogen. And the mitogen gives you global T cell stimulation, where the CMV antigen gives the activation of the T cells. So these cells, the blood is drawn into these vacutainer tubes, and up to 1 ml in each tube. And then you incubate this tube for overnight at 37 degrees. And then you measure interferon gamma in the plasma. And this actually a graphic representation shows you how to predict or how to analyze the QuantiFERON results. If the patient shows interferon gamma levels after stimulation with CMV peptides above 0.2 international units, it's considered to be a safe level, that there is a robust CMV-specific T cell response, and we don't need to worry about this. If the patient shows below 0.2 international units, it's considered to be high risk. The patient is likely to have complications associated with CMV. And here is an example how we have used this QuantiFERON kit to monitor stem cell transplant patient. Here you're seeing two different patients shown in the high risk group and two patients in the low risk group as a representative. The darker lines are shown here are the CMV QuantiFERON response, the reactivity in the test tube. The dotted lines are the viral load, and on the top you see these gray bars are actually the antiviral drugs. As you can see, this patient number on both high risk patients continue to have much lower QuantiFERON and seem to be losing the immunity, and the viral reactivation starts and becomes persistent in this patient. Whereas those patients at the low risk, actually who show high level of QuantiFERON response, show very little viral reactivation and maintain a stable immunity against the virus. We've also shown that in the same study where when you actually have a negative QuantiFERON response by day 60, by 2 months approximately, you have a very high probability of CMV reactivation up to 80%. Whereas if you are CMV positive, QuantiFERON positive by 2 months, you have a much lower chance of CMV reactivation. So clearly showing the acquisition of a positive QuantiFERON-CMV test is coincident with protection from CMV reactivation. Similarly, another group headed by Autologous at the Toronto General Hospital have also conducted studies in kidney transplant patients. They've shown again that if you are CMV QuantiFERON reactive, you have a very, very low chance of getting any evidence of CMV disease in these patients. Whereas if you are CMV non-reactive, that is if you don't have a reconstituted immunity as measured by QuantiFERON assay, you have an increased risk of CMV reactivation. In fact, Atul has again extended this work, has now actually shown that post-prophylaxis, you can actually measure the CMV QuantiFERON, you can measure CMV immunity using QuantiFERON technology. And if you are actually positive for CMV reactivity, that is your T cell immunity is normal and have you reconstituted, you actually don't need to give any further treatment and it can remain CMV free. If you're non-reactive and if you don't treat these patients, they have a very high chance of getting CMV reactivation, as shown in the red line here. Having established the immune monitoring as a diagnostic strategy or predictable strategy for identifying patients who are high risk of infectious complication, particularly viral infection, we have taken one step forward and tried to bring in a new form of clinical management where we use adoptive T cell therapy for treatment of CMV, EBV, or other viral complications in these transplant patients. In fact, T cell therapy has now emerged as a powerful tool to manage viral infection in transplant patients. A number of clinical centers and biotech industry is rapidly coming into this particular area and trying to develop new strategies using either autologous or off-the-shelf T cell therapies for treatment of viral infection in transplant. Here is an example of a patient who we treated with CMV-specific T cell. This was a stem cell transplant patient who actually developed a very severe CMV colitis following allogeneic stem cell transplant. As you can see here, this patient had a very severe bleeding in his colon, and you can see these brown dots which actually indicate CMV replication going on, and the histology clearly shows severe damage by the viral infection. And when the patient came to us, he was having multiple diarrheal episodes, and we were able to grow CMV-specific T cells from patient's own blood. And when we gave him the T cell therapy, within 6 months, the patient was completely cured and showed a complete resolution of CMV colitis, and the architecture of the colon returned to the normal, and there was no detectable CMV reactivation in the gut anymore. Here is another example of a pediatric patient who actually developed CMV retinitis, which is an infection in the eye. And we actually were able to get the immune cells from his donor And in this case, the patient actually had a very high viral load in the peripheral blood and also in the retina. And there, when we grew the immune cells, the patient received 2 cycles of 6 T-cell therapies. And each of the cycle, the patient showed a dramatic improvement in the viral load and showed a complete resolution of CMV retinitis, as shown in the images here. We have also treated young kids with adenoviral infection with post-stem cell transplant. Here is an example where actually we're seeing rapidly replicating viral load with the green line, and we gave multiple infusions of adoptive T cell therapy and the patient showed a complete resolution of adenoviral infection. We've also used these T-cell therapies to treat solid organ transplantation, not just stem cells. In this case, this is a patient who had a lung transplant because of the underlying cystic fibrosis. And within a few weeks of post-transplant, patients started to develop EBV-positive lymphomas in the liver. And in this case, the patient, we draw the blood and we were able to grow the immune cells, in this case EBV-specific T cells, and patient showed complete resolution of these lymphomas by 20 weeks. Clearly showing you the power of these immune cells, particularly the in vitro manufactured T cells, for the treatment of multiple viral infections. And particularly we have been very interested in treating the CMV-associated complications in solid organ transplant patients. Previous studies have shown that long-term use of prophylaxis, as I mentioned earlier, often leads to drug resistance. And once the patient develops resistance to drugs like ganciclovir, they have a very high chance of having mortality or high level of morbidity associated with this particular drug resistance. A few years ago, we started a clinical trial using the CMV-specific T-cell therapy in renal transplant, heart and lung, and heart transplant patients. And what we do is, in this process, we manufacture the CMV T cells from we take the peripheral blood from the transplant recipient, and we mix these with the CMV PEP mix, which is actually a combination of class 1 and class 2 restricted epitopes. And these cells are then cultured for a short period with IL-21, which leads to the expansion of the T cells, and then we add what we call IL-2 growth factor, IL-2, and these cells then rapidly expand within 2 weeks as a large number of. These cells undergo very stringent testing for microbial contamination, and also they go through cellular and potency testing as well. Once the cells are fully characterized, they can then be transferred back to the clinic for infusions, and usually we give around 1 to 2 10^7 per meter square. We have a dedicated facility at our institute which is specifically designed to manufacture these cell-based therapies. This is one of the largest cell therapy manufacturing facility in Australia. We have 14 clean rooms, and of each of these covers around 2,000 square meter area, and has been fully licensed by TGA for T-cell therapy manufacture for clinical trials. Here is the characterization of CMV T-cell products that we have manufactured from multiple patients. And on the left-hand side corner there, you can see these T-cells. When we expand, they're predominantly around 90% cells are T-cells of these combination of CD8 and CD4 T-cells. You do see some NK cells in there and very small proportion, probably almost negligible, B cells. And in the second graph from the left, you can see there is the frequency of CMV-specific T is a dramatic increase once you expand these T cells over 14 days. And we noticed that regardless of the transplant, we could expand T cells from all different all different patients. And also, it didn't matter whether the recipient was CMV negative or positive before the transplant. We could expand comparable number of T cells, although there was a trend of better T cell expansion in CMV positive recipients compared to CMV negative. The safety profile of this T cell therapy, absolutely brilliant. In fact, we have hardly seen any T cell therapy associated severe adverse event. Generally, these are mild to moderate. The patients might report nausea, malaise, or fatigue, or sometimes they might have additional sort of symptoms, which generally are not necessarily associated with T cell therapy. Quite safe to give these T cells. In fact, this is quite a complicated table, not to sort of go through each bits of it. The simple story is that we recruited around 13 patients, And of those, 11 patients showed clinical improvement, and 5 were complete responders. That is, we could completely resolve either their CMV disease or the viral load, and 6 had a partial response, and 2 had no response. So this actually was a very clear-cut indication that how powerful or how CMV T-cell therapy can be used for the treatment of these patients. Here's an example of one of those patients. It was a kidney transplant patient, and you can see this red line with the red dots is the viral load. The blue line is the CMV-specific T cells, which are actually making interferon gamma. The black line shows the actually polyfunctional T cells, and clearly as the patient is given T cell therapy, shown by these black arrows, and they actually show the resolution of the viral infection, the T cell immunity improves, and you can see that as the T cell immunity improves, the viral load goes down, the patient shows a complete response. At the same time, we also see the reconstitution of what we call the CD8 positive, CD57 positive cells, shown in the red line. And of course, it's coincident with the reconstitution of CMV immunity. And of course, we have done a bit more complicated immunological sort of analysis, what we call TCR repertoire remodeling. And all the patients who show clinical responses show beautiful reconstitution of T cell immunity, but also you get to see this by deep sequencing, remodeling of the T cell receptors. The whole repertoire changes with time in these patients, so they're clearly showing long-term establishment of CMV-specific immunity in these patients. In spite of these successes in these patients, there are a number of challenges, and one of few of those challenges are the autologous cellular therapy manufacturing from transplantation is often very complicated, and we do see failures, particularly specifically in those patients who are lymphopenic and who have been on the antiviral drugs for too long. We actually need to develop rapid access T cell therapy for critical ill patients, because their time period between the disease onset and the time that it takes to manufacture these tests often is quite long. And also we have to identify precise clinical correlates of successful cellular therapy. One of the approach that we have been collaborating with Atara Biotherapeutics is to develop this what we call off-the-shelf approach. What the off-the-shelf approach is, it's such a powerful one that you can actually take immune cells from healthy donors and take the peripheral blood mononuclear cells from the blood collected from healthy virus carriers like you and I, and then these cells are actually sensitized with the antigen. They're grown in the bioreactors, and you can grow these multiple doses of T cells and store it down in liquid nitrogen. And what you do is that you then match these T cells with the appropriate transplant recipient, and using a proprietary algorithm, and that cells can be shipped to the patient within 24 to 48 hours. Rather than taking 2 weeks or 2 to 4 weeks, we can now provide these T cell therapies off the shelf within 48 hours. Here is an example of a study conducted by Atara Biotherapeutics in collaboration with this Memorial Sloan Kettering Institute. Here they were showing beautiful, clinical responses up to 60+%. Overall survival when you're given the EBV-specific T cells, which had been grown as an off-the-shelf T cell therapy, allogeneic. There are few treatment-related serious events, very few, no infusion-related toxicities, no cytokine release syndrome, and only one case of graft versus host disease, showing just remarkable results, both in hematopoietic stem cell transplantation and solid organ transplant. The remarkable thing is that the overall response is pretty similar, around 60%. There have been a number of studies now been published, around close to 300 patients been treated. And what is more interesting is that you can see how many CRs are there, their complete response, and very few adverse events. Very rarely the patients have been showing any adverse effect of the T cell therapy. So just imagine these are the T cells which have been expanded from healthy volunteers and have no relationship to the patient, and used as a third-party T cells, and they're extremely safe and give a beautiful clinical response. Just to summarize, I think the long-term, what we're going to move away from autologous to off-the-shelf T cell therapies. And here are my acknowledgements. My colleagues at the QIMR Berghofer Medical Research Institute, particularly Corey Smith, Leonie Begley, Archana Panikas, Veera Rehan, Gary Brooks, and Linda Jones, and many others who have contributed to this many years of work of developing these T-cell therapies for various infectious complications. And my clinical colleagues at Royal Adelaide Hospital, Princess Alexandra Hospital in Brisbane, Prince Charles Hospital and Royal Brisbane Hospital again in Brisbane, and the staff at the QGen Cell Therapeutics, where we actually manufacture our T-cells. Thank you very much.
Thank you, Professor Khanna, for the great presentation. From this morning, we had 5 speakers in this theme, and we have learned a lot of different innovative approaches from them. Let's take a small break and join again for live Q&A shortly. Thank you.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough, or maybe a triumph, a constant struggle, a clash of ideas. We can make a difference, create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?